Good afternoon, everyone. It is my honor to introduce the speaker of today's Grand Rounds, Dr. Richard Auchus. Dr. Auchus is a professor of translational medicine in the Department of Pharmacology and Internal Medicine at the University of Michigan. He also serves as chief of endocrinology section at the Charles Kettles Veterans Affairs Hospital. Dr. Auchus and his group are active in a wide range of research projects, including basic biochemical principles and structural biology of steroid biosynthetic enzymes, comprehensive steroid mass spectrometry analysis, and clinical trials and translational investigation in disorders of the pituitary, adrenal, ovaries, and testes that cause hypertension, infertility, and obesity. His clinical interests also focus on pituitary, adrenal, and reproductive diseases that involve disorders of steroid production. And he's particularly interested in the care of adults with genetic disorders of steroid biosynthesis. He has authored more than 350 journal articles and 40 book chapters. He has lectured in a wide range of national and international conferences. He was elected to the Association of American Physicians in 2018 and was chosen to deliver the prestigious Lawson-Wilkins Lecture for the Pediatric Endocrine Society in 2022. He received the Frontiers in Science and Distinction in Endocrinology Award from the American Association of Clinical Endocrinology in 2023 and was the 2021 recipient of the Outstanding Clinical Investigator Award from the Endocrine Society. Dr. Auchus will be presenting on a practical approach to the occult epidemic of primary aldosteronism. Please join me in welcoming Dr. Richard Auchus.
Okay, it's great to be here. Anything to escape the Michigan winners. Although we do have an important football game coming in about a month. All right, so I'm going to give you my disclosures first, and then I'm going to launch into this topic. And I'm going to break it into three sections: screening, subtyping, and the tip of the iceberg. And this talk should have something for everybody. No matter what you do in medicine, you should take away something that will help your patients from this lecture. All right, so where did it all start? So it started in Ann Arbor in December of 1954, about 70 years ago. What actually happened is that a woman from the Toledo area was admitted with a potassium of 1.8, and she had hypocalcemic tetany secondary to hypokalemia. And also had hypertension. Now, Jerome Conn was the chair of endocrinology then and worked closely with Steve Fyans, who discovered MODY, and the patient was actually admitted to Dr. Fyans. And Fyans knew that Conn, during World War II, was studying acclimatization in the South Pacific. So our troops were going to the Japanese theater, the Pacific theater, and they were passing out their first day on maneuvers there. And they realized that there was an acclimatization process. So Conn turned the floor of the University of Michigan hospital into a jungle. You know, he kept the humidity and the heat high, and he brought people in, and all he could measure was sweat chloride, right? And he figured out that it took 3 days for your sweat chloride to drop to almost zero. And he knew from animal studies that there was a hormone from the adrenal, which he called electrocortin at the time, that was responsible for this acclimatization. Then, and this was in the 40s. Then in 1950, Reichstein and the Tates discovered and isolated and characterized the structure of aldosterone. They realized that aldosterone was in fact this electrocortin hormone. Fyans then, knowing the physiology of that, said this patient must have an electrocortin or an aldosterone-producing tumor. Dr. Conn should see the patient. And Conn spent 2 weeks, you can't do this anymore, and you need an IRB to do it, and, you know, doing all this. And remember, Conn could not measure renin, and he could not measure aldosterone, and he didn't have CT scanning. All he had was sweat chloride, and he still figured it out. He still understood that the hypertension and hypokalemia must be due to aldosterone excess. And so he convinced a team of surgeons to take out both her adrenal glands. And it turns out that the team that was operating on the right got there first, and they found a tumor on this adrenal. And he said, okay, you guys on the left can stop. And in fact, the patient was cured after that. So that's how it all started. So now if you want to start a fist fight at a hypertension meeting, you talk about how common primary aldosteronism is. Some people, nobody will argue it's less than 1%. Some people will say 10%, some people will say higher. It's probably about 8%. It's higher in resistant hypertension for sure. But even if it was only 1%, it's still a huge problem because about 30% of American adults have hypertension. And so that's about 100 million people with primary aldosteronism, okay? And we barely scratched the surface. It is the #1 treatable risk factor for cardiovascular disease, stroke, and CKD. And it doesn't even meet criteria for a rare disease. So I asked the House staff, have any of you worked up a patient with primary aldosterone? They say no. And I say, how many of you have at least 5 patients with treatment-resistant hypertension? They all raise their hands. I say, you've all seen primary aldo, you just haven't diagnosed it yet, okay? So that's what I want to talk about. So who do we screen? So for sure, hypertension and hypokalemia, that's a no-brainer. Treatment-resistant hypertension, absolutely. Or people who are controlled with 4 drugs. But also you should think about whenever you're considering secondary causes of hypertension, because it is the most common secondary cause, people with hypertension at a young age or a strong family history of hypertension or a stroke at a young age, advanced stage 2 hypertension, hypertension and a known adrenal mass or sleep apnea, which are enriched populations, and hypertension with a first-degree relative who you already know has primary aldo. Or you could just screen everybody. Now, in fact, in Japan, everybody with hypertension is screened for primary aldosteronism. Now, I think that may be a little bit over the top, but we have this problem because we're just not screening enough people. So if you look at the Endocrine Society clinical practice guidelines, so if you have one of those criteria, we recommend in aldosterone and renin to do what they call case detection. I actually think of it more as you must rule out primary aldo with a normal aldosterone and renin. And if they have low hypokalemia, a suppressed renin, and an aldosterone greater than 20, there is nothing else that does that. I mean, there is nothing else on your differential diagnosis. You've already made it. And then you don't need to do any confirmatory testing. If not, you leave that up to us, the endocrinologists. We do the confirmatory testing, the cross-sectional imaging, and then we send most people to adrenal vein sampling. I don't want to get, we do probably 4 adrenal vein samplings a month at the University of Michigan. That's part of our research interests and so on. I'm not really going to talk about that today. I'm going to talk more about the beginning and the end of the evaluation because that's where everyone gets involved. But you notice that there's 2 final common pathways. Either you have a laparoscopic adrenalectomy or you get put on an MR antagonist. And my goal today is to get more people on MR antagonists. Okay. All right. So how well are we doing? All right, so this is a study that Brian Bird, who's one of our cardiologists that works with the adrenal team, was involved with, where we looked at screening for primary aldosteronism amongst the VA population. And so they just took people with treatment-resistant hypertension, which remember, in rich population, everybody should be screened for primary aldo. And these light green bars are the people who are not being screened. And those little dark green bars at the top, that's the people that are being screened. And so at the bottom, that percentage, and it's only about 2% of people with treatment-resistant hypertension that are being screened. So 98% of these people are not being screened, which is pathetic. Now, what is the value of screening? Well, if you go through the consort diagram here and you look at people tested and people not tested, the important thing is not the people who had adrenalectomy in the tested group. That's only a minority. The important thing is the people who got put on MR antagonist. It's 4 times higher in the people that got tested than the people that didn't get tested. And so that's the reason that you screen. You screen so you identify people the occasional person who benefits from going to an endocrinologist and eventually gets an adrenalectomy. But what's more important is that you say this is a person who is a good candidate for MR antagonist therapy. And screening is really not about aldosterone. It's really more about whether renin is suppressed than whether aldosterone is high, because as I'll show you later, the best predictor of response to MR antagonist is a low renin. Doesn't matter what your aldosterone is, but if your renin is low, you have a great response to MR antagonist therapy. Now, one question I want to dispense with early on is that people often feel paralyzed because the previous people that worked in primary aldo and the Europeans and the Japanese go through these diatribes about how critical it is to prepare the patient properly, and that all these drugs that they modulate the RAS system, and so you can't screen people if they're taking all these different drugs. And that's totally not true, okay? Because if you think about it logically, most drugs that we use to treat hypertension are either diuretics or vasodilators. And both of those groups will raise your renin. So if your renin is still suppressed, your aldosterone should be 0, right? And no matter what drug you're taking, if your renin is low, your aldosterone should be 0. So drugs do not cause false positive screen. Now, they can cause a false negative screen by raising your renin, but if it does, you probably don't have very bad primary aldo and you probably don't have a tumor. So I don't stop drugs. I just screen people no matter what they're taking and see where they are in that state. Now, it can take up to a couple weeks if they're already taking MR antagonists, which is uncommon, but actually a lot of people with significant primary aldo that I see in my clinic, they still have a suppressed renin despite spironolactone. So the best drugs are an alpha blocker and verapamil. And if you have a high index of suspicion, you can always whittle away on the drugs and then rescreen them. So how good is this? How good is this aldosterone-renin ratio? So if you use aldosterone in nanograms per deciliter and renin activity in nanograms per mil per hour, and you use a ratio of 20, you get about 80% sensitivity and 80% specificity. So not bad as a screen. But what you notice is if you start to go to higher values, you only pick up a few more people. Your sensitivity improves, your specificity improves a little bit, but your sensitivity plummets. So you really miss a lot of people. So I like to not calculate ratios. I actually look at the two values independently. So the first example is someone with modest aldosterone, mid-range renin, ratio of 2, normal potassium, doesn't have primary aldo of any sort. So I don't do anything with this person. Now, notice the second person has an aldosterone that's very low of 3, but a renin that's totally suppressed, and the lab reports it down to 0.1 nanogram per mil per hour. So the ratio is 30 because you're basically dividing by 0. And that's one of the reasons I don't calculate ratios, because this person definitely does not have primary aldo, but probably would benefit from MR antagonist therapy. All right. Now, the third person is has a pretty high aldo, a low renin, a high ratio, borderline potassium, needs to go on to confirmatory testing. The next patient, the aldosterone is not as high, but they have a potassium of 2.9. You can bet the farm that this person has primary aldo, probably a tumor, because hypokalemia impairs your ability to make aldosterone even from a tumor. So in the presence of hypokalemia, a modestly abnormal aldosterone is highly, highly diagnostic of primary aldosteronism. And then the last patient, this is an example of someone with primary aldo taking spironolactone. So very high aldosterone. Renin is not suppressed, but the ratio is high enough to make me suspicious enough to stop medications and rescreen them without them. Now, a lot of labs, including our own, has switched over to direct renin assays, which are in picograms per mil rather than the renin activity. And just a plasma renin activity of 1 equates to a direct renin of 8 to 9 or 10 picograms per mil. So I'll show you some examples of that later on. And we even did a correlation of plasma renin activity and plasma mass. And you see the slope of the line is about 9. So the correlation is about 9. It's a very good correlation. There's a couple of outliers there, but most people are very good. And you notice at the low end, which is what we're talking about most of the time, because most human beings in the United States are salt loaded and haven't made aldosterone in years. And so, you know, most of the renins that you're dealing with are in the activity is in the 3 or less range. And you see low plasma renin activity will give you a low renin mass. All right, so like the Nike people say, no excuses, just do it. Screen for primary aldo. All right, so that part was easy. And now it gets hard. And this is where the endocrinologists get involved. But for the internists, you can stop here and just treat medically, all right? And that's kind of, again, the message that I have. But I want to talk a little bit about the further stages of the workup. So there was an international group that we were involved with called the PASO group, the Primary Aldosterone Study Organization, where we looked at data on success of adrenalectomy. Because there are reports dating back from the 50s on this, and the success of adrenalectomy was highly variable because it depended on what your criteria for success was. So you can stack the deck against you or for you. So what we did is use the Delphi method to come up with definitions for complete, partial, and absent success for both clinical outcomes, meaning hypertension, hypokalemia, and biochemical outcomes, meaning aldosterone lowering. And there were 31 experts, 28 centers, 6 surgeons, about 700 cases about that had biochemical data. And we used adrenal vein sampling in all these centers to guide surgery. And the answer is that complete biochemical success, if you use adrenal vein sampling, is 94%. I mean, that's pretty darn good. So if we use adrenal vein sampling, we can find the source of aldosterone, remove it, and correct the aldosterone excess almost uniformly. But the clinical success, meaning normotension without drugs, is complete in only about 1/3 of the cases. But it's partial in about half the cases. And the clinical success is more likely in women versus men and younger versus older patients, because older patients tend to develop essential hypertension as it is. And clinical success is less likely the more medications you're on, the older you were, and if you're a man. So this kind of established standardized criteria for primary aldo management, for study interpretation, and also for counseling patients about whether or not only should we have surgery, but should we even bother to do cross-sectional imaging and adrenal vein sampling. So the reason this is important is because CT scanning is only about 50% accurate. And the reason is that 5 to 10% of adults have nodules on their adrenals. And just because you see a nodule doesn't mean it's the nodule that's making the aldosterone. So if a young person who's, you know, the adrenal nodules increase with age. So in young people who have high convincing clinical parameters for an aldosterone-producing adenoma, such as hypokalemia, we sometimes operate on them without adrenal vein sampling. But so far, we really don't have any other alternative. And surgical outcomes are definitely better, like the 94% that we saw in the PASO study, if you do adrenal vein sampling. So there is some work on nuclear imaging studies for aldosterone-producing adenomas. And C11 metomidate has gotten the best press on this. Metomidate is a selective inhibitor of aldosterone synthase, the CYP11B2 enzyme. That is the only enzyme in the body that can make aldosterone. And it's only expressed in aldosterone synthesizing tissues in the adrenal. So this C11 labels allow you to do PET imaging of cells that are making aldosterone. So I've shown a couple of examples here. You have the upper left has an aldosterone-producing adenoma where you see the tumor on the CT scan and it lights up on the PET scan. The other adrenal is fairly cold, and the overlay shows an aldosterone-producing adenoma. All right, that's kind of a no-brainer. The one on the other side, the bilateral hyperaldosteronism, unremarkable looking adrenals, similar uptake on both sides. That's pretty typical. But you have false positives and false negatives with this. And so I've given you two examples of incidentalomas that seem to have disproportionate uptake compared to the other adrenal that can be misleading. So we're not there yet. It's not available in the United States. Maybe someday we'll have some sort of nuclear imaging test that will allow us to avoid adrenal vein sampling, but it's not ready for prime time at this point. So why do we do adrenal vein sampling? Now, I could show you 1,000 cases. I'm going to show you one. This is a guy I took care of when I was in Dallas at Parkland Hospital, 42-year-old Hispanic man. He's got treatment-resistant hypertension. He's on a boatload of potassium. He has a low renin. He has an aldosterone that's sky high. His 24-hour urine aldosterone, where the upper limit of normal for aldo is about 12 or so, is 217. So just looking at him, he's young, he's male, but he's still young, and he's on a lot of drugs. And so he's likely to lateralize, and he's likely to benefit from adrenalectomy. So we proceeded to CT scanning, and he has a nice 1.5 centimeter left adrenal mass, but he also has a 5 millimeter mass on the right side. So here's the nice big tumor on the left, and then the little dark tumor on the right. So, you might say, well, let's take out the bigger size first, but we sent him to adrenal vein sampling. And so what the radiologist does, Jim Shields is our guy in Dallas, he threads catheters from the groin up into the adrenal vein, pulls a sample, and then we give a bolus and an infusion of co-secretion, and then we pull more samples. So you look at the left adrenal and right adrenal vein cortisol values, because cortisol only comes from the adrenals. And if you're in the right place, the cortisols will be high relative to the mixed venous blood. We call that the selectivity index. And we do that because it's very difficult to cannulate the right adrenal vein. So we got to make sure we're in the right place first. So in those first couple of samples that he pulls, we send those to the lab, and the lab lets it clot and then runs the cortisol values right away, so we know if we got good samples. Then we give the co-secretion and pull a couple more samples. And then if we know we're in the right place, we then send those for aldosterone and cortisol measurements. And we look for the cortisol-corrected aldosterone values. We divide the aldosterone by cortisol because you can get a very clean adrenal vein sample, or you can get a very mixed adrenal vein sample. So the higher the cortisol, the cleaner an adrenal vein sample it is. So we divide the aldosterone by the cortisol, and then we look at the two sides, and that's called the lateralization index. And with co-secretion, a value of 4 is considered lateralized. And we also like to see the low sides be less than the mixed venous blood, because then we know the aldosterone is not coming from that other adrenal. And we see two common patterns, one that suggests lateralized, where we have a very high aldosterone cortisol ratio on one side, less than 2 on the other side, and the IVC is somewhere in between. And when people are bilateral, the two adrenal vein values are usually in the 2 to 4 range, and the IVC is a little lower than both of those. All right, so what did this man have? Well, the aldosterone on the right side was 26,000. So it's actually the little tumor that's making the aldosterone. And I could stand here all day and show you examples of this, but I'm only going to show you one just to show why you cannot trust CT scanning to tell you where to operate. Now, a couple other cases to describe the spectrum of primary aldosteronism. So older man, hypertension for 30 years, hypokalemia, never been screened, all right? And he has a CT and his adrenal veins look normal, but he's otherwise healthy. This is the only medical problem that he struggled with. So we talked to him. And he wanted to go through with it. So we CT'd him and we did the adrenal vein sampling, and he clearly lateralized that the aldosterone to cortisol ratio on the right adrenal vein was sky high compared to the left adrenal vein, and the left adrenal vein was lower than the inferior vena cava. Now, what did I promise him? I didn't promise him that we were going to cure his hypertension, but I said, you know, if you lateralize, you will probably not have hypokalemia. We can get you off the potassium supplements, and instead of uncontrolled hypertension on 4 drugs, we can have you controlled on 1 pill a day. All right. And it was lateralized to the right. He had a right adrenalectomy. His aldosterone was completely suppressed after surgery, and he had normal blood pressure and potassium on 2 drugs. That's a win. Okay. I mean, he's not cured, but that's a win, because he's going to be very easy to manage for the rest of his life. Now, compare that to this guy. All right, so he's 51-year-old, resistant hypertension, hypokalemia. CT shows a 1.5 centimeter right adrenal mass, very likely to lateralize, already has a tumor identified. And we do adrenal vein sampling, and the aldosterone on the right, where the tumor is sky high, definitely lateralizes to the right. So we take the right adrenal vein out, and he still has primary aldosteronism. It's much better, and he's normal kalemic, and he has normal blood pressure on 2 drugs, including an MR antagonist. What went wrong here? Well, I think the question is, why do you get bilateral hyperaldosteronism? Why is primary aldo so common? And for years, people didn't want to accept that primary aldo was so common, just like people didn't want to accept that cell phones, everybody's going to have a cell phone, and didn't want to accept that everybody that's over 75% of them have osteoporosis. What is the pathogenesis of primary aldosteronism? And that came about only in the last 10 years, when we've had a very selective antibody to stain for that aldosterone synthase enzyme. So unlike what the textbooks say, if you take an adrenal gland from a free-living American human being and you section their adrenals and you stain it for aldosterone synthase, you don't see a nice continuous zona glomerulosa like you see in a rodent or in a child. What you see are patches of staining. So sort of like this APCC8, where you see just on the left lower quadrant, one patch, a cluster of aldosterone-producing cells. And we call these aldosterone-producing micronodules. So if you think about it, we are living in a natural selection process by virtue of being in a salt-loaded society. So the only cells that can survive and make aldosterone are cells that don't need renin to make aldosterone. So we are all generating these aldosterone-producing micronodules over time. And when you look at them, they increase with age, and they have mutations in the same genes that we know cause aldosterone-producing adenomas. So these are driver mutations that allow aldosterone to be made and aldosterone synthase to be expressed in the absence of renin and angiotensin II. And when you do principal component analysis on their gene expression profiles, they look like zona glomerulosa cells, and they have very high expression of aldosterone synthase. They're called APCCs on that curve. So all of us are generating this over time, and some of us will have bilateral overproduction, which will be bilateral hyperaldosteronism. Some of those will turn into tumors, and that's a unilateral aldosterone-producing adenomas. And the last patient I showed you has both. He has critical mass of aldosterone-producing micronodules on both sides, and one of them turned into a tumor. Okay. Now let's talk about these tumors, these aldosterone-producing adenomas. If you do gene expression profiles and you look at the steroid metabolizing enzymes, the difference between APAs, the aldosterone-producing adenomas, and the cortisol-producing adenomas, the CPAs, is that the cortisol-producing adenomas do not make this CYP11B2 aldosterone synthase enzyme. That's a no-brainer. But what's odd is that the aldosterone-producing adenomas also express CYP17A1, the 17-hydroxylase enzyme, which you do not need to make aldosterone, but you do need to make cortisol. So it actually turns out that these aldosterone-producing adenomas themselves are heterogeneous. So if you do the immunohistochemistry, so this is a patient with primary aldo, lateralized to this side, took out the tumor, cured the primary aldosterone, stained the tumor, H&E, and with these different enzymes, there's actually two populations of cells in that tumor. There's a population of cells that express CYP11B2 and are making aldosterone, and there's a population that express CYP17A1 and make cortisol. And together, they form the tumor that you identified with a CT scan. And in fact, sometimes the tumor that we identified, which on this image is the T1 tumor that we saw on the CT scan, doesn't make aldosterone at all. It's this little T2 tumor that we never saw that actually is making the aldosterone. So we don't do partial adrenalectomies anymore for this reason. If we lateralize this adrenal, the whole adrenal is going in the bucket. And then we're going to sort out later where the aldosterone is coming from. The other point that this makes, because there can also be these other enzymes expressed, is that most aldosterone-producing adenomas also make a little bit of cortisol. And this is now called Cushing syndrome. And it was first identified in the urology literature years ago. They had people with larger tumors that they identified with primary aldosteronism. They took the tumor out and they had adrenal insufficiency post-op. And the reason is because they were also making cortisol, and people didn't notice this, and that was suppressing their HPA axis. And so the other adrenal was asleep, and they had to wait for that to recover. And that's big tumors, and we've kind of known this for years, tumors over 3 centimeters. But what about small tumors? So the group in England did this study. They took healthy controls, people with primary aldosteronism, about half of whom had aldosterone-producing adenomas, 47 people with overt Cushing's and 100 people with mild Cushing's, and then some non-functional adrenal tumors. And they looked at total urine metabolites of aldosterone and cortisol in all these groups. And they found elevated cortisol metabolites in the aldosterone-producing adenomas that resolved with surgery. So this is showing in panel A is tetrahydroaldosterone, the main metabolite of aldosterone. And so it's obviously elevated in the primary aldo people and not in the other groups. But when you look at panel C, which is the total glucocorticoid metabolites, it's of course elevated in the people with Cushing's, CU on the far right. But the second highest group is the people with primary aldo, okay? And so there is a little bit of cortisol production in people with primary aldo as well, which may also contribute to their hypertension. So a colleague of mine in Dallas was working up a 46-year-old Vietnamese woman who had recurrent pregnancy losses, and it was thought because she had resistant hypertension and hypokalemia that there was a problem. So she was referred to the cardiologist, and she screened positive for primary aldo, and she was hypokalemic, but her 24-hour urine aldosterone was just slightly elevated. But still met criteria. She had a CT, she had a 3-centimeter right adrenal mass, and that's shown here. So this nice plump mass between the liver and the spine is that 3-centimeter adrenal adenoma. And then that little thing between the left kidney and the pancreas is the left adrenal. And so she was sent to adrenal vein sampling, and it was a successful study. The cortisols were kind of low on the left side, but it appeared that the lateralization was to the left side, not to the right side where the tumor was. And the reason is because she has Cushing's, all right? And so she had overt Cushing's, an elevated urinary free cortisol, and a suppressed ACTH. So the reason that it lateralized to the wrong side is that the cortisol was suppressed on that side, and we were dividing by a falsely low cortisol. So they did have a good left adrenal vein sample, but we picked the wrong analyte to normalize to in this particular person. So when they have both primary aldo and cortisol, and they have a large adrenal adenoma, we know the cortisol is coming from that side. We take out that adenoma, and then we reassess for primary aldo afterwards. Because aldo is easier to treat medically than Cushing's. And Cushing's we want to treat surgically. So this kind of diagrams it out. So the cortisol production from the tumor suppressing ACTH, suppressing cortisol production by the other side. So this is why we DEX suppress everybody. Now, I'm not going to show you this. We can talk about this afterwards, but this has led us to look for other analytes that we can normalize the aldosterone to. So we do a lot of comprehensive steroid mass spectrometry. Adina Turku, who's my partner with Bill Rainey, have used these alternative steroids like 11-hydroxyandrostenedione and so on to salvage these studies that are equivocal when we use cortisol as the denominator. And the other important thing about the expression of 17-hydroxylase in these tumors is that a lot of these aldosterone-producing adenomas make these hybrid steroids that we thought were only made in rare genetic forms of primary aldosteronism. So this is another biomarker that we can potentially use to decide who we want to send on to CT scanning and adrenal vein sampling instead of doing it in everybody. Because again, I think the Europeans have tried to make it, and the Japanese tried to make it too complicated. And we're trying to make it simpler, and we're trying to come up with these guide points that tell you which people benefit from going on to the later stages of the evaluation. So compared to the Endocrine Society Clinical Practice Guidelines, Adina and I came up with this alternative flow sheet that kind of is a little more practical for thinking about how many people I'm going to go on further. So if they have a positive screen, if you thought to screen them and they're negative, they probably should be on MR antagonists, just like in the VA study. And if they're a surgical candidate, well, if they're not, you put them on MR antagonists. But if they are, then we think about how likely are they to lateralize? And then if they lateralize, how likely are they to have clinical success? So if they have hypokalemia, high aldosterone, presence of tumors, young age, short duration of hypertension, female sex, very likely we're going to benefit these people. So then we go on to the whole 9 yards. We do the CT, DEX suppression test, adrenal vein sampling, try to get them to adrenalectomy like that first patient I showed you. If it's not so likely, then we just put them on MR antagonists. Now, they don't respond well, they have side effects. You can always go back and re-enter the workup later on. Okay, but at least you have something that any internist can do that you can help these people with because you screen them for primary aldo. And then there's a couple of side points on here that, again, I don't want to get into, but the other important point is that we evaluate everybody for concomitant hypercortisolemia. If it's substantial and they have convincing evidence, we just do the adrenalectomy without adrenal vein sampling, like that last patient I showed you. All right, so that was complicated enough. Now we all know about subclinical hyperthyroidism and subclinical hypothyroidism and asymptomatic hyperparathyroidism and osteopenia. Like a lot of the stuff we do in endocrinology now is not overt disease. So there's got to be like a subclinical primary aldo, right? You just don't wake up one day with primary aldo. There have to be some people that are between normal and what we've conventionally defined as criteria for primary aldo. So who is in that gray zone? And it turns out to be a lot of people. All right. So first thing you got to remember is, as I told you, that most Americans have not made aldosterone in years because of our salt-loaded society. So when I was in Dallas, we measured aldosterone in 4,000 people in the Dallas Heart Study. The most common value we got was 0. Okay, 0, because like 50% of people don't make any aldosterone. But then you got this curve going out, and some of these people, it's because they're on a low salt diet. Some of these people, it's because they're on medicine. Some of these people have primary aldosteronism. And remember, 40% of them have hypertension. And so Anand Vaidya and Jennifer Brown have started digging into this. So they've done population-based study where they take everybody with a low renin, and then they do the gold standard, which is, they do serum aldosterone, but they also do 24-hour urine aldosterone. So if you look at people with quartiles of suppressed renin, the higher your aldosterone, even in the normal range, the more likely you have hypertension, right? It doesn't apply to people with with the higher renin, but if you have a low renin, then you have a graded response of hypertension to how high your aldosterone is. And if you do the gold standard 24-hour urine, if you take untreated normal tension and you use a cutoff of 12 as primary aldo, 15% of people with normal blood pressure have primary aldo, okay, but no manifestations. Now, maybe their blood pressure was 110/70 before they developed this, and now it's 122/80, all right? And then people with untreated stage 1 hypertension, also about 15%. Untreated stage 2 hypertension, now it's about 35%. And untreated treatment-resistant hypertension is about half that have primary aldo. And it's not a bimodal distribution. It's a continuous distribution. So there is normal, there is primary aldo, and there is everything in between. It's a continuum. And the higher your aldo, the more likely you have hypertension. And the higher your blood pressure, the more likely you have primary aldo. And we don't even know what number to use because all those other papers have been done with immunoassays. And now all the referral labs are using mass spec assays. So with the we measured aldo in my lab by mass spec and compared it with the immunoassay. The immunoassay reads about 30% higher at pretty much all aldosterone levels. So any number you have in your head, you can't be wedded to a strict cutoff. You have to think about it as a continuum, and that the higher the aldo, the more likely it's contributing to the hypertension. So rather than obsessing about the numbers, okay, that's why we want you to think about how likely they are to lateralize, how likely they are to benefit from surgery. And everybody else gets MR antagonists because from the Ascot study and from David Calhoun's lab, we know that it's the only drug in the formulary that drops your blood pressure by 20 to 25 millimeters. And you don't need high doses. And I'll talk about that at the very end. And in the Pathway 2 study did this in a placebo-controlled, double-blind way where they took people with treatment-resistant hypertension at baseline. They gave them placebo. You have a little study effect. They randomized them to spironolactone, doxazosin, or bisoprolol. The winner, hands down, spironolactone. It's only 25 to 50 milligrams a day. And what was the predictor of what the magnitude of your blood pressure response was? It's your renin, not your aldosterone. Lower your renin, the better your blood pressure response. So all those people with a renin less than 0.5 in a non-study with hypertension, they should be on MR antagonists. Okay. All right. So now for cardiologists, we made it simpler. So, if they meet screening criteria, any of these things, measure renin and aldosterone, the renin's low, then everybody should either be on MR antagonist or see an endocrinologist, okay? If the renin's not low, you should still consider an MR antagonist. If the renin's high, then probably something else is going on. Now, pearls to using MR antagonists, I think a lot of people aren't trained to this. I always start with spironolactone because it's $4 a month. Anybody can get it. And I start with a half of a 25 milligram pill a day, 12.5 milligrams a day. And you'll be surprised at what kind of blood pressure lowerings you get with 12.5 milligrams of spironolactone. And I usually get chemistries in about 2 weeks or 1 week if they have CKD. And I wait at least 4 to 6 weeks before I up titrate. There are two effects of spironolactone. Spironolactone works on the kidney to cause salt and water retention, but it also works on the brain to activate your sympathetic nervous system. And that effect on the brain takes a longer time to manifest than the effect on the kidney. So wait 4 to 6 weeks, and if they're not controlled or still hypokalemic, I double the dose. I keep doing that until either they have side effects or they're controlled. I want their blood pressure normal, their potassium at the high end of normal, and ideally their renin not suppressed. And then if they have a really great response, I start whittling away the other drugs and try to get them on 1 or 2 treatments alone. Now, they will get a bump in their creatinine because primary aldo is a hyperfiltering state, but it should only be a few tenths of a milligram per deciliter, and it should stabilize. And you may have to stop or reduce the dose. In fact, some people can get hyperkalemia from this, and then you can actually add a thiazide diuretic, right? Because at that point, then you've corrected the hypokalemia issue. So if they get side effects, I switch to eplerenone and I double the spironolactone dose and divide it twice a day. So 50 of Spiro, they get side effects, I give them 50 of eplerenone twice a day. And then I keep doubling it as I need to. And amiloride is an alternative. It's not as ideal because it doesn't block the MR in the heart and in the vascular system, but it actually works quite well, particularly on the hypokalemia, but also on the blood pressure. So screening is easy, but underutilized. You don't wake up one day with primary aldo. We now understand the pathophysiology of the aldosterone-producing micronodules, which explains the high prevalence. We also understand the co-secretion of cortisol. And don't worry about screening. You can always stop and treat medically because MR antagonists are the best drug for resistant hypertension. All right. So as Albert Einstein said, everything should be made as simple as possible, but not simpler. And I always like to close with reminding you that the adrenals are life and the rest is just details. Okay. All right. Now I'll close for questions.
Thank you, Richard, for that amazingly well put together didactic lecture that I'm sure everyone enjoyed. Maybe before I open the floor up to questions, let me just ask one myself. So I get the concept of subclinical hyperaldo, and you recommend screening and treating for that.
Resistant hypertension and, and I think, I don't recommend screening everybody, but if you're having trouble controlling their blood pressure, you ought to screen them.
Right. Okay. So the question is whether or not by doing that, do you fend off eventually the development of a adenoma, or do you just sort of delay the inevitable where they're eventually going to end up going for surgery at some point anyway?
Right. Great question. Do we alter the natural history of the disease? We don't know that yet, but that's what Anand is trying to study. So he's taking these people early on that we previously didn't identify, and then he's tracking them longitudinally. So I hope in about 10 years, we'll know the answer to that.
Yeah. And I would try and stay away from the term subclinical, even as it pertains to thyroid, because if they're symptomatic, they're not subclinical.
Absolutely.
It's just below the radar of the clinician.
Yep.
Anybody online or before we get to the online, anybody in the room with a question or comment? Yes, Dr. Mendel. How often you see
repeat it for yes. How often you see gynecomastia with spironolactone? At 12.5 and 25 milligrams a day, almost never. You start to see it about 50 milligrams a day, and you see it more in older people. So, when I start people on that low dose, there's two reasons for it. One is that they're unlikely to get side effects from it, and it is dose dependent with spironolactone. And then I just have a ballpark idea of whether they're going to respond or not, and whether I should keep going. Because just like statins and everything, you get your biggest bang from the smallest dose. What if I already have a patient with gynecomastia? I guess I start them on eplerenone.
Yes.
Yeah, that's a really good question. So there are some like Cushing's. We don't screen people for Cushing's in the ICU because their cortisol is going to be high. But primary aldo, what I say is wait until they're out of their acute phase and they're getting ready for discharge. So once they're stabilized, then I would go ahead and screen them. Usually they're not on, you don't want to screen people when they're hypotensive, right? So, but if you see somebody who comes in with AKI, and you're wondering if there's a component of that, you can screen them.
So, okay, Dr. Bernal Mizrahi.
Yes. Yes.
issue, or is something that
Yeah, so the question is, are the aldosterone-producing micronodules clonal? So Bill Rainey has looked at this because they do laser capture microdissection and then single cell sequencing. In each micronodule, they are clonal, but two micronodules on the same adrenal are not the same clones. They're different clones. So they're different clonal subpopulations. Very good question. Yeah.
Let me go back to your initial presentation of the VA study by Conn.
Yes.
I was intrigued to see that even in the group, the majority, which did not get workup for primary hyperaldo, a significant number underwent adrenalectomy. What possible reason did they have to do adrenalectomy without doing a workup?
Yeah, so it's not in the study, but they probably got a CT scan and found an adrenal mass.
So,
and that's not the right way to do it.
okay, that I think is an important point that we shouldn't walk away with. Well,
there's a question over there.
Yeah, please.
Well, what I can tell you is the Yanomami Indians in Brazil have is that you? Ah, yeah. Okay. So they have basically a salt-free diet, and they live with an aldosterone of 100, 150. And Roger Grecken went down there and studied them years ago. Nobody has hypertension.
Great. This was a wonderful grand rounds. Thank you so much, Richard. Welcome to Miami.
All right.